Hi, my name's Jess, and today as part of this video blog tutorial, I will be speaking to you about kidney stones, the various substances that cause them and their clinical manifestation. I will also be discussing the various diagnostic options and the associated management. I've included a number of diagrams throughout this PowerPoint presentation to assist with your understanding of this topic, and I will now also very briefly go over some important anatomic and pathophysiologic aspects of the renal system for those that might be a little bit rusty. I've also included a really good YouTube video below this post, which has a great explanation and animation showing the renal system and kidney function. So if you feel like you want a bit more information, please click that link and have a little look. Okay, so the renal system is a group of organs that work together to produce, store, and release urine. The kidneys are a vital part of the renal system. They're located on either side of the back portion of the abdomen. Every day, the kidneys, the body's major excretory organs, filters more than 200 litres of fluid from the bloodstream, allowing metabolic waste, excess ions and toxins to leave the body in urine whilst returning necessary substances to the blood. As with any major system within the body, homeostatic imbalance within the renal system can cause major issues for the patient and can often result in serious illness, often requiring hospitalization and in some cases minor or major surgical intervention. One particular imbalance can cause calcium, magnesium, or uric acid salts in the urine to crystallize and precipitate in the renal pelvis, thus forming renal calculi or kidney stones. Most stones that develop under 5 millimeters in diameter are able to pass through the urinary tract without causing problems. However, as seen on the current slide, large calculi have the potential to obstruct a ureter and hence block urine drainage from the affected kidney. This blockage in the kidney causes a significant increase in pressure, which causes excruciating pain that radiates from the flank on the affected side around to the anterior wall on the same side. Pain can also occur when the contracting ureter closes around the stone. I'll talk a little bit more about the pain associated with kidney stones and its clinical presentation a bit later in this discussion. Okay, so the mechanism for stone formation differs depending on the chemical composition of the stone. Whilst the specific cascade of events for stone formation is unknown, we do know that the stone formation requires the following 4 things: supersaturation of one or more salts in the urine, precipitation of the salts from a liquid to a solid state, stone growth through crystallization, and the absence of stone inhibitors such as citrate that inhibit the growth and aggregation of calcium-containing crystals. Okay, so as you can see in front of you now, there are currently 5 major types of kidney stones. Today, however, I will just go over 3 of the most common stones: calcium oxalate, uric acid, and calcium phosphate. Calcium oxalate stones are the most common, accounting for approximately 85% of presentations to hospitals. Calcium oxalate stones are created when calcium and oxalic acid are combined. Calcium is a highly abundant atom found in urine, and when introduced to oxalate, a charged ion and strongly acidic waste product that the kidneys remove, the two combine by an attraction of their matching and opposite charges. There are 2 different types of calcium oxalate stones: calcium oxalate monohydrate and calcium oxalate dihydrate. Monohydrate stones appear more frequently when high levels of urine oxalate are present and are therefore harder and more resistant to fragmentation by lithotripsy. This type of stone is generally caused by an interplay between diet and lifestyle factors and a family history of renal calculi. Calcium oxalate stones generally present at sizes between 1 and 10 millimeters, and most of these stones that form at less than 7 millimeters are able to be passed without the need for surgery or lithotripsy if they are able to move from the kidney and into the ureter. The risk of damage or injury to the affected kidney is low with this type of stone. However, the risk of injury is high if a stone causes a complete obstruction. Uric acid in its molecular form is organic. meaning that it is composed of carbon atoms strung together, in this case in the shape of two linked rings. Due to the fact that there is a much higher concentration of uric acid in urine than oxalic acid, these stones can become very large, often big enough to block the entire collecting system in the kidney. Unlike other stones, the makeup of uric acid stones does not require a combination of atoms and molecules to create a crystal, and because of this, uric acid crystals can form exceptionally fast. If these crystals are retained and not passed in the urine as a fine gravel, they can grow rapidly into very large stones, sometimes over 20 millimeters in size. The cause. Okay, so highly acidic urine is common amongst obese or diabetic people, and in those diagnosed as having gout or kidney disease. Due to the fact that uric acid crystals have the ability to absorb products of hemoglobin breakdown, the stones can appear as a red or orange in pigment, and often pass in urine as a red or orange gravel. If retained and a stone is formed, it can appear as white and chalky if hemoglobin breakdown products are not absorbed. Because the entire process of uric acid stone development depends solely on the acidity of the patient's urine, this type of stone is relatively easy to treat and prevent. Introduction of a modest amount of supplemental alkali should make the urine of most patients alkaline enough to allow the hydrogen atoms to be removed from the charged nitrogen, which allows water to bond so that the uric acid remains in a solution. I will talk a little bit more about dissolution therapy a bit later. So finally, we have calcium phosphate stones. There are two different types of calcium phosphate stones, brushite and hydroxyapatite. Both stones are made of a combination of calcium and phosphoric acid, but create a different type of crystal. Brushite is made from an equal mixture of calcium and phosphate ions, whereas hydroxyapatite, which is the mineral that makes bones hard, is created from uneven proportions of the two minerals. Hydroxyapatite crystals are most likely to plug the kidney tubules and injure the kidney cells. Okay, so clinical presentation. Once the stone enters the ureters, the renal colic phase begins, and several other symptoms than the ones you can see in front of you may become apparent. Renal colic pain has often been reported by patients as being the worst pain imaginable, worse than the pain of broken bones, childbirth, and full-thickness burns. This pain is described as radiating from the flank around to the inner thigh or genital region, and in addition to the previously mentioned symptoms, renal colic pain can cause nausea and vomiting, diaphoresis, hematuria, and pallor, as well as an increase in frequency of urination without an increase in bladder volume. So, diagnosis and investigation. Any patient who has developed a renal stone stands a greater than 20% chance of recurrence. For this reason, it is important to identify metabolic imbalances or structural abnormalities so that appropriate management can be commenced. Diagnosis of kidney stones can be done in many ways. The following imaging studies are the most commonly used in the diagnosis and evaluation of kidney stones. Imaging should be conducted urgently on presentation in order to establish a firm diagnosis as quickly as possible. So CT-KUB. Non-contrast enhanced CT is the most commonly used diagnostic imaging study as it has a higher specificity and sensitivity, which is most suited to the detection of renal and ureteric calculi. So plain abdominal X-ray can clearly and accurately show the size, shape, composition, and location of opaque urinary calculi, as well as enabling for assessment of total stone burden. This diagnostic imaging study is often used in conjunction with renal ultrasound or CT-KUB. Renal ultrasound is the most effective for stone and kidney analysis. It allows a clear picture of size and shape of stones and abnormalities in the kidneys. Intravenous urography provides a clear visualization of the entire urinary system and can be used to identify location of problematic stones, which may be causing an outlet obstruction amongst many pelvic calcifications. This investigation is performed by injecting IV contrast, which is excreted into the urine by glomerular filtration, and highlights the passage of urine from the kidneys when scanned. Urinalysis. Urinalysis enables assessment of for hematuria, presence of white blood cells, and crystal fragments. Additionally, urinalysis allows for measurement of urine pH. Biochemical screening for stones. A 24-hour urine collection should be ordered if recurrent urinary tract calculi occur. This recurrence should raise suspicion of conditions such as hyperparathyroidism, cystinuria, hyperoxaluria, or idiopathic hypercalciuria. This collection will measure calcium, phosphate, oxalate, and uric acid excretion. The composition of past or removed stones should also be analysed to determine their exact makeup. So all of the tests that I've just mentioned can be used to rule out conditions that may mimic the clinical presentation of kidney stones, such as appendicitis, cholecystitis, diverticulitis, and pyelonephritis. Okay, so risk factors. Kidney stones are currently believed to be the third most common urological condition in the Western world and affects more males than females. Although most stones are thought to have no demonstrable cause, a number of risk factors have been identified. The greatest risk factor to be identified is a family or personal history of stones. A genetic predisposition towards the accumulation of several stone-forming minerals or a lack of protective factors is also thought to play a significant role. Additionally, severe dehydration, dietary imbalance involving a high-sodium diet, obesity, gout, and digestive conditions have also been identified as significant risk factors. Digestive conditions such as inflammatory bowel disease or chronic diarrhea can cause changes to the body's digestive processes and affect absorption of water and calcium, which increase the levels of stone-forming substances in the urine. Okay, so surgical management. First of all, we have stent placement. A ureteric stent may be temporarily placed into the ureter for several reasons in relation to renal calculi, such as allowing drainage around a stone, to allow healing after a ureteroscopy, to help reduce pain from a stone, or to allow drainage when an infection is present. Stones are placed during surgery by sliding over a soft guide wire, which is placed up the ureter and normally stay in for no longer than 2 to 3 months and are removed either on the ward by nursing staff or intraoperatively. Percutaneous nephrolithotomy. A percutaneous nephrolithotomy is a minimally invasive procedure to remove stones from the kidney by a small puncture wound through the skin. This procedure is most effective for removing stones which are more than 20 millimeters in size and are present near the pelvic region. If the stone is too big to be removed using the sheath, the stone may first be crushed using ultrasound probes and then the fragments removed. Shockwave lithotripsy is the most common treatment for kidney stones in the US. High-frequency shockwaves from outside the body are targeted at the kidney stones, causing them to fragment, and the stones are broken into tiny pieces resembling sand and are easily passed urethral. The success rates vary depending on stone composition and size, but can be from 60 to 90%. Ureteroscopy. Endoscopic ureteric stones can be removed by passing a fine telescope called a ureteroscope up the urethra and into the ureter to locate the obstructing stone. This procedure allows for direct inspection of the ureters and bladder and is performed using a flexible fiber optic instrument that allows for biopsy samples to be taken and for stones or calculi to be examined, crushed, and extracted. So an open or percutaneous nephrostomy. A nephrostomy is an opening that is created between the kidneys and the skin. A nephrostomy tube is a thin plastic tube that is passed from the back, through the skin, and then through into the kidney to the point where the urine collects. The purpose of the neph tube is to temporarily drain the urine that is blocked, allowing the kidney to function properly and protect it from further damage. Okay, so conservative management. First of all, we have IV hydration, analgesia, and observation. So stones under 7 millimeters are often able to be passed without intervention, although often very painfully. Conservative management of renal calculi often involves a combination of IV hydration, analgesia, and observation of the patient, including straining their urine to check for stones or fragments of stones. Another form of conservative management is the use of dissolution therapy. Non-surgical management of uric acid stones can be achieved by the use of dissolution therapy. This involves the use of alkalizing agents, increased fluid intake, and lowered blood uric acid levels. Alkalizing agents are taken orally on a regular basis, such as potassium citrate or potassium bicarbonate, or known as uril and citrovesin. These work to normalize the urine pH levels. Allopurinol taken regularly also works to lower blood uric acid levels. Whilst dissolution therapy is not as immediate a solution as surgery, it is well tolerated and highly effective in the dissolution of non-obstructing uric acid stones. Okay, that's all for my presentation today, but if you have any questions about anything I've mentioned, please post them below and I'll get back to you as soon as possible. Thank you.